Good evening. My name is Ralph George. I'm the creator and the founder of Smilefy. Please joining me in welcoming Dr. Salvatore Lotardo, an accredited member and former president of the American Academy of Cosmetic Dentistry. With more than 25 years of clinical experience, Dr. Lotardo is recognized for his expertise in managing complex multidisciplinary cases. He's a dedicated educator, regularly lecturing on advanced restorative and orthodontic techniques. In today's webinar, Dr. Lotardo will share his practical step-by-step system that empowers clinicians to deliver predictable and exceptional aesthetic outcomes for their patients. So thank you very much, Dr. Lotardo. And we are super excited to see the presentation.
Well, thank you very much, Ralph. And welcome to all the attendees. And thank you for attending this webinar. I want to take you through a comprehensive workflow that I use, which incorporates Smilefy's digital art software. Using this cutting edge technology, I'm able to systematically and efficiently diagnose and design. We'll work through a case from start to finish, and we'll show you how we can predictably deliver optimal outcomes, as we just previously mentioned. So we're calling this tonight, hold on a second. There we go. Now I'm active. Diagnose, design, and deliver. So we have all had a patient like this come into our office, especially if you've been practicing for more than a few months. This is a very common appearance for many of our patients nowadays. And this patient comes in with the chief complaint, my teeth are chipping away. Now, your patient or that patient that comes in, it could be they're coming in because they say their teeth are getting smaller or shorter, or they're starting to see through their teeth. They're becoming more translucent. Or maybe they have come from the dental office and they're fed up because the restorations or the bonding keeps chipping. We know there's more going on than what the patient is understanding, so it's important for us to process this case properly. Now, what happens for many dentists is we jump to treatment planning. So the patient comes in and we start immediately going into a treatment plan discussion. Or I mentor a lot of young dentists. They'll send me a case similar to this or a couple of photos, and they say, "Hey, doc, I'm thinking about doing veneer. Should I do 6 or 8?" Or maybe the patient is coming in because they have some crowding and the dentist is asking me about Invisalign. Or, the teeth are worn and we're talking about opening up the bite and doing a full mouth reconstruction. Once again, we're focused often on the treatment plan and ignoring the diagnosis. And it's partly our fault and partly the nature of dentistry nowadays. If you look at all the coding that we have to follow for insurance, it's predominantly treatment and procedural codes. Then, on top of it all, patients come in asking for treatment. So we fall into that trap. But if you would imagine going to your physician and walking into his office and saying, "Hey, doc, I'm starting to have some heart palpitations, having some restless nights sleeping," and he reached into his drawer and started writing you a prescription for some drug, you'd be like, "But wait a minute, why am I like this? What's happening?" You wouldn't want to just have the treatment and walk out the door. So I think we have to get into that mindset. And there's a crunch time for many of us. We're doing exams, we're bouncing back and forth from the operatory to operatory sometimes. Now, I'm fortunate enough where a lot of patients will come and seek me out for cosmetic treatment or some complex treatment. And I will do a free consult for these patients. And some of my colleagues will say, "Oh, don't do free consults. That's not a good idea." But I really feel like if a patient's going to invest a lot of time and money, they have the right to come and meet me, discuss the case with me, and see if we vibe, if I'm the right doctor for them, kind of get an idea of what the cost will be. But since I'm doing a free consult, this assessment essentially has to be very quick and efficient. And so I break it down. I need to hear their chief complaint. So this is where you get an opportunity to win some points with your patient, because most patients are usually complaining that no one listens to them and understands what they're talking about. So you need to spend a few minutes trying to get the chief complaint. Now, sometimes patients will kind of talk and talk and talk. So you have to kind of make it as concise as possible for them. Then your next step is you need to do a very quick and efficient clinical impression. This may be just taking a quick look around the mouth. Now, the more experience and knowledge you have, there aren't that many different things we see day to day in dentistry. So you can kind of get a good feel for what this patient is going through and what's causing their condition, what they may need. Now, the key to this appointment is educating this patient. And you're not condescendingly, telling them how much you know, but you're sharing your knowledge. You're, kind of winning them over, kind of getting a chance to let them see that you're an expert and you have a lot of confidence and you have a lot of experience in dealing with these cases. And this communication with them is really what's going to make or break the case acceptance. Then, once again, I'm not getting paid for this, and I want to make it very concise. And then at some point, I have to say, listen, if we want to take this to the next step, I need to get some more information. I need to get some records. I need to do an analysis of your entire smile and your oral condition. And that's going to take some time, and that's going to take some investment on your part. So what I normally tell them is it's $500. I need to do records and a smile analysis. Now at that point, maybe they're not so interested anymore, and that's fine. They're maybe not ready at this point, or maybe the money scares them away. If someone's not willing to spend $500, just to get the ball rolling here, then chances are they're not that serious at this point. So, but oftentimes patients will say, wow, can we do it now? And if that's the case, then we got the ball rolling. And the next thing I really need to do is I need data. And what do I need this data for? Is because this is the information that I'm going to use to start putting this puzzle together. And the data is going to be, of course, we need medical information like we normally do. We're going to do our routine standard dental clinical exam, looking for caries, perio health, soft tissue pathology, TMJ, all that stuff. And then we get into the digital world where we're collecting a lot more information that we're going to then utilize later with our Smilefy and our other technologies. So we need digital photography, we need digital scans, radiographs, cone beam, any kind of jaw like or occlusal digital products that you may be using at this time. So now we've got our data, and computer's not working again for a second. Hang on a second. There we go. So we've got our data. What are we doing with all this data? Well, we're going to compare all the data that we collect to the known metrics that we have. And these metrics are going to allow us to start to put together the diagnosis. So getting back to our physician analogy, you walk in, you're having heart problems, he's going to send you for some blood tests. He's going to send you for an EKG. And what he's going to do with that data is he's going to get a printout, and it's, a lot of values in the blood test, and they're going to be flagged whenever there's some sort of deviation from the standard numbers. And that will clue him in, okay, I've got this, I've got that, and he starts putting together. Now, they have a tough job for sure, but being a GP in dentistry, you have to be an expert on a lot of things, or you have to know a lot about a lot. So these are the metrics we're dealing with nowadays. You have aesthetics, you have airway, you have all sorts of occlusion aesthetics, perio, ortho, biomechanical, and the list is probably even longer. So we have to then take all our data, look at all the known metrics that we have, and then come up with a diagnosis. Once we get the diagnosis, that's when we can really start talking treatment plans, because anytime you start talking treatment plans in a serious way without a diagnosis, you're not really behaving like a doctor. So now, a lot of metrics. We don't have time to go over everything tonight, and I don't always go through every single metric, but especially for these kind of cases, I'm going to start and focus in on aesthetics. Now, the beauty is with the Smilefy software, we already have a head start built into the algorithm, and with the AI-driven technology, we have a lot of these metrics already built into the system. But nonetheless, it's important that we understand all the metrics and we understand how they're going to affect our case, or maybe how they point to certain diagnoses. So I like to break up my aesthetic metrics into face, smile, white, and pink. This is something that I've modified over the years through my working with the American Academy of Cosmetic Dentistry. And it's a simplified version and a simplified way to kind of go through the case and get most of the pertinent information that you need. So I'm going to spend the first half of this webinar kind of going through some of these metrics so that when you're working with your Smilefy design and you're working up your diagnosis, you can see how everything correlates. So we got the face, we have the smile, we have the white, which is the teeth, and we have the pink, which is the gums. Let's start with the face. We're going to look at face type. We're going to look at profiles. There's also symmetry we have to look into. Cants. We're not going to go over all these in any detail, but I'm going to try to focus in on some of the ones that might be more pertinent to our case that we're going to run through tonight. So for face type, I still like the traditional rule of thirds. We look at a patient's face, it's divided into thirds. It should be roughly equal distribution. And if so, we're calling that patient a mesocephalic patient. On the lower third of a mesocephalic patient, or a normal or standard patient, the metric is the upper teeth and the maxilla should take up about a third of the vertical, and the mandible and the lower teeth, 2/3. Now, when we get to deviations from normal, we look at a long face, which we call dolichocephalic. And if in the lower third, the mandible, the lower jaw is dominating more so than our normal metric, we might call that patient prognathic or class 3. We can also have a patient with a dolichocephalic long face, but the lower third, the maxillary teeth and the jawbone takes up too much of the vertical component, and that might be a maxillary excess patient. For the short face, and especially the short lower third patient, they're brachiocephalic patients. Typically, these are patients that are kind of red flags. First of all, they're difficult to treat orthodontically sometimes. They have very strong muscles of mastication. They resist teeth moving, and they're also high risk for our restorations. They've typically managed to break and wear down their natural teeth, and so now we're putting our restorations into kind of a hostile environment here. So that's always important to understand. Let's take a look at profiles. In ortho, we say the E plane is from the tip of the nose to the chin. And if the lips are behind that line, we classify that as concave. If they're somewhat at that line, that's a straight profile. If the lips start extending out beyond this line, now we're talking about probably a convex profile. Now, there's no right or wrong profile, and there's a lot of ethnic and racial variability, which is fine. But you have to understand how these profiles may affect your treatment decision and your outcomes. So for the woman all the way on the right with the very convex profile, if she's got a lot of crowded teeth and I'm looking to do Invisalign or align her teeth mostly by advancement of the teeth, well, now I might make her more or too protrusive. And on the flip side, for the patients on the left that have the concave profiles, well, I don't want to do any retractive dentistry for sure. And maybe for them, additive dentistry or advancing dentistry would be better, especially for women who are looking for more lip support. So we can also use the profile to kind of replace the CEP. Most of us are general dentists, I'm assuming, on this webinar, and you don't have a CEP. Now I do a lot of my own ortho, so I have a CEP, but we can use some soft tissue landmarks to kind of give us some more metrics for aesthetics. And so, glabella subnasale to begonia forms an angle, and we like to see those patients in that 165 to 175 degree. And that kind of gives us a perspective of the upper jaw related to the lower jaw. We also can kind of, utilize these photographs instead of cephs for some traditional cephalometric positions, like where is the facial plane of the anterior tooth. So if we drop a horizontal perpendicular to glabella, we would like to see that central incisor plane somewhat near that line. And you can see it's pretty predictable when you match up the face to a cephalometric X-ray. So let's move on. I'm not covering everything. I'm going to just highlight some of the more pertinent points here. So let's look at the smile. The incisal edge position is really, for me and most people, where you want to start evaluating the smile. Is the current central incisal edge position in the right position, or does it need to be changed? Is this where we're going to, or how we're going to get to that position? Is it up or down? Now, there are other education centers that use other reference points, canine, or maybe even lower teeth, but I still think this is the most simple and easy way to get your starting position. Then we have smile line or occlusal plane. Here, this is more of a visual metric. So there's not a number associated with this, like many things in maybe medicine, but we have a lot of visual metrics, and this is one of them. What we want to see is we want the incisal edges to kind of form a nice curvature that mimics a smile and kind of files along with the lower lip curvature. And my computer's frozen again. There we go. So now the next thing is tooth reveal or tooth display. In the resting lip position, for an average young female, we're looking at about 3 to 4 millimeters. So that's a nice metric to have to say, hey, this is what I'd like to attain, because most patients are wanting to look younger. They want to have more youthful smiles. They want to show more teeth, typically. Now, for gingival display, the standard for saying someone has a gummy smile is maybe anything over 2 millimeters. But there's literature that suggests lay people and even dentists really don't find a smile detracted from a beautiful smile up until you get to about 4 millimeters or more. So it's kind of, there's some subjectivity here. But I'm going to take a little bit of a deeper dive into this, because this is one of the chief complaints of the patient that we're going to work through. She says she has gummy smile. So we have to understand, well, what is causing her to have this gummy smile? So there's a differential diagnosis, and I like to go through it in this specific order, and you'll see why. It kind of makes things very simple. The first thing we have to eliminate is vertical maxillary excess. So we look at the lower third of the face. If they have a long lower third of the face and the maxilla is more than our metric of about a third of the lower third, that's one clue. If the excessive gingival display is both in the anterior and posterior, well, now I'm pretty sure this is a maxillary excess patient. And if that's the answer to this is yes, if this is a VME patient, well, really, our treatment choices start to get limited, because they really need orthognathic surgery or some type of maxillary impaction to really make a big difference for them in this condition. But if they're not VME, then we go and we take a look at the lips. And what we're looking at here is, do they have short upper lip? Well, once again, the metric is for a young female, it's about a 20 to 22 millimeter length from the base of the nose to the wet dry border. Um, for hypermobile lips, the normal would be 6 to 8 millimeters measured from repose to full smile. So, and this is from the Robbins Global Diagnosis book. If it's yes to either, in other words, if the patient has a short lip because their measurement is less than 20 millimeters, or they have a hypermobile lip because they they smile higher than 6 to 8 millimeters. Once again, this is not really something that restorative dentistry can fix. This is more in the realm of doing Botox to limit the smile, or maybe some type of advanced perioplastic surgery to kind of reposition the lip. So if the answer is no, we've eliminated short upper lip and hypermobile upper lip, we're now going to look at super eruption. So for super eruption, which we call dental alveolar extrusion, the normal metric would be that the maxillary anterior and posterior teeth create a continuous horizontal gingival line. So if we're looking at a normal patient, we see this pattern. The gingiva running across the top of the gingival architecture forms a nice, symmetric, continuous curved line. Now, for super eruption, there's two types. There's without wear, and in this case, it still forms this continuous line, but you can see that it drops down in the anterior. So it's actually not a continuous line. It's a parallel line, but it's not continuous. And why are these teeth super erupting in this pattern? Well, this is the category of some orthodontic patients, malocclusions, where the maxillary teeth basically super erupt because they have no opposing dentition to stop them. So we see that in class 2 div 1. We also see that in class 2 div 2, where the teeth super erupt into a deep bite, or they super erupt and they also have a tremendous amount of overjet. So, but it's really the same patterns, but it's about recognizing these patterns and understanding what's causing the gummy smile. Now, if it's an ortho patient like these, you're going to do a class 2 correction with some type of intrusion and bite opening. If it's not an ortho, unworn class 2 type of issue, now we're going to look to see, is this patient getting super eruption secondary to wear? They still have that same pattern, but now the teeth are worn. And that's going to bring us to a different kind of set of circumstances here. Now they have compensatory eruption from, a pathologic attrition. Now, if the answer is yes, it's still going to be an orthodontic treatment to intrude these teeth, and then a restorative treatment to add back the worn amount of tooth, or the worn away amount of tooth. Now, sometimes people will say, hey, well, can't I just do crown lengthening on these patients? You can, but I mean, it's more invasive, and you would be so much better to put the tooth back into the correct position and then add back and not have to deal with doing surgery and other things that complicate things with crown lengthening. I've heard people also mention in these cases, hey, can't I just open the vertical? Well, opening the vertical in a case like this, number one, is not going to solve the gingival display. They're still going to have a gummy smile, and you're probably over-treating the case. You're probably doing more restorative work on teeth that don't need restorative work. Now, if it's not super eruption that's causing the gummy smile, then we have to look and see, we've eliminated all these. Does this person have short teeth? And why do they have short teeth? So there's a differential diagnosis within the short teeth category. And that is, let's check to see if the CEJ is detectable in the sulcus. And if it is, well, then they just have very short teeth for some reason. But this is super rare. And I've been practicing for over 25, close to 30 years. And, you rarely see just very short teeth. most likely you're going to check this patient and the CEJ is not there. It's in the gingiva someplace or below the bone. There's some type of altered passive eruption going on for this patient. And the treatment plan is fairly simple. It's a facial crown lengthening. So once again, the patient's got a gummy smile. The teeth look short. There's no wear. There's the CEJ can't be found. It's an altered passive eruption case. And we correct that with some crown lengthening and get her back to a much more natural, much more beautiful looking smile. All right, so that's gingival display. Now let's take a look at buccal corridor. This is another one of our criteria that's basically kind of a little subjective. It's a visual. There's no number to say a measurement per se on the visual perception of buccal corridor. So when this patient walks into my office, and this is a patient I saw probably 15 or 16 years ago, and she only wanted 6 veneers. And I could tell going into it, that's not good. We probably should do some more posterior treatment to get her a wider, fill that buccal corridor. And this is what it looks like when you have a buccal corridor deficiency. Now, she was very happy and she's been my patient forever. And secretly, when she comes in for a recall exam, I'm almost hoping one day that I can do some of the bicuspids. And maybe I should have just done them for free to make this case look even better. But anyway, that detracts from the smile, in my opinion. And so it's another metric that we have to consider: is the buccal corridor properly developed? Then we got the teeth, which is the white. And obviously there's proportion, shape, contour, and texture. Probably the most important thing is the individual proportion of the central. Now, we like that width to height ratio to be 76 to 82%. You'll see it in textbooks of 76 to 80%. I've seen a lot of beautiful smiles where 82 is fine. This is important because we're going to reference all the other teeth based on this height to width proportion. So getting this right really sets up the case. Then we have embrasures, and we have incisal and gingival embrasures. There's even other embrasures, but incisal and gingival embrasures we're going to look at next. There's no right or wrong size embrasure, but we want to see a natural progression from smaller to larger, from anterior to posterior. And that we all agree on will look better. So that's another aesthetic metric that we want to see. We want to see that progression. You can certainly have a beautiful woman with a beautiful smile with very small embrasures. And you can have a beautiful woman and you can have a beautiful smile with deep or large embrasures. And I'm kind of showing you my age here because I'm showing you actresses from the 80s and 90s. I guess I have to update these at some point with, I don't even know, Taylor Swift or somebody else. But anyway, so we've got our embrasures. We've got contacts. The 50-40-30 rule is kind of a guideline. It doesn't always have to be exactly this, but we also want to see that progression from a long contact anteriorly to progressively getting shorter in the posterior. You don't have to be a dentist or a lab technician or any kind of aesthetic, uh, minded person to know this doesn't look good. And maybe some patients don't understand why this doesn't look good, but we understand that contact length is very important for aesthetics. Now, emergence profile or inclination, as the orthodontists talk about it, I think is really critical and sometimes gets overlooked. Now, I do a lot of ortho in my practice, so I'm in tune to this maybe a little bit more because every bracket has an inclination built into it and precisely for each particular tooth. So you can be really particular about what inclination you like. So Lawrence Andrews, way back when, who invented the straight wire appliance, he said he thought in nature a 7-degree central inclination or torque looked the best. There's probably a good range for these, but basically you want to look at the crown torque or the inclination. It has to be positive. So whether it's 7 degrees, 8 degrees, or 10 degrees, it has to be in that range. If the tooth is much more retroclined, that's when it starts to look bad and it's, detracting from the smile. Once again, we can use photographs sometimes. If you can't take a ceph or look at a cross section of a lateral to determine the inclination, you can look at a photograph. And I usually always take this lateral view perpendicular to the lateral incisor, and I can compare and sort of estimate the inclination of the central compared to the occlusal plane and get an angle. So ideally, we like that to be in the 85-degree range. Greater than 85 degrees, and it's starting to look too retroclined, and less than 85, it's sticking out too much. It's more proclined. Now we've got axial inclination. And once again, restorative dentists have certain terminology, orthodontists have other terminology. So they refer to this as angulation or tip. Us restorative dentists, we think of this as axial inclination. I go back and forth. But if you think about angulation or tip, all the upper teeth and most of the lower teeth, maybe you can even argue all the lower teeth, have some type of mesial crown tip. So the actual number is maybe less important as making sure that they're all consistently mesial tipped. And you can see when you have axial inclination variations, it detracts from the smile. Doesn't look harmonious. So some people use the analogy of all the axial inclination angles should be pointing towards the belly button. Since I'm American and I eat a lot of McDonald's and I love French fries, the McDonald's French fry container lines up the French fries kind of to emulate the axial inclination. So however you want to remember it, just make sure you have that look. It's very important. So that's our axial inclinations. And the orthodontists, once again, they can really fine tune the individual axial inclination or angulation or tip of every tooth by determining what bracket they're using and the prescription for the bracket. Maybe we don't have to go into that much detail, but some general guidelines, some general metrics for how much tip, is good to follow. Color, there's not really that many metrics with color, but we know that, hue, chroma, and value. We know value is very important, and that's something we have to factor into our design and our eventual treatment plan. Now, with relative proportion, I know we're moving more towards 3D smile frames. The 2D smile frames are not accurate, but however you do it or whatever you use, if you use golden proportion or something else, uh, we're looking for some sort of harmonious relative proportion from each tooth type. And critical is also you always want to have that central dominance. When you lose central dominance, you lose a lot of the character of the smile. Of course, there's interarch relationships. There's a lot of other orthodontic metrics, but overjet, we want 2 or 3 millimeters, overbite, 20% or less. Of course, having an angle 1 classification is another sort of helpful metric, and there's plenty of cephalometric metrics. With airway and with people wanting widening smiles, I like to always have some of these metrics handy because I want to make sure that I've got proper, transverse development from my patients. Now, the pink is more in the perial realm, but there's a few things in the pink that I want to cover. Gingival architecture, we know the gingival margins have a certain pattern. The centrals and the canines are at a similar height, and maybe the laterals are down 1 or 2 millimeters. That's considered sort of an ideal setup. Now, black triangles are very important also because patients don't like black triangles, and they'll take a long contact over a black triangle any day. What's very important about black triangles is everyone's doing Invisalign and doing a lot more adult orthodontics. Adults are very susceptible to developing black triangles, especially if they have overlapping or heavily rotated teeth. So you have to have a plan in place before you do that, because if at the end of the treatment you end up with black triangles and the patient's like, I don't like these, well, you're going to be probably doing a lot of composites for free to close up those black triangles. So have a plan in place to predict that you're going to have black triangles and have a restorative agreed upon treatment plan to fix those at a later date. If you happen to not get them, then great, patient will love you. Pheno and biotype is important. It determines how we can move teeth, how, how predictable recession might be for certain cases. And then, of course, contour, color, and texture always is important. So let's get back to our patient. So we've gone through an assessment of data, metrics, and now we have to put all these pieces together and come up with a diagnosis. And then we can deliver some treatment plan options to the patient. Now, the treatment plan is basically the design. That's the design element of the treatment, uh, of this whole sequence, basically, is the treatment. And if you think about it, the diagnosis is the why. Why is this patient looking the way they're looking? Why are they having things break? Why are they not happy? Why is their smile not really what it can be? The what is the design. What are we going to do? What are we going to design? What are we going to change to make sure that we address the diagnosis and treat it properly? And the how is the delivery or the execution. So this is where, if you're a builder, the architect puts together the design, and it could be this beautiful, very intricate design. And now the builder has to figure out how to construct it. That's sometimes one of the hardest parts. But if you have a great design, then it makes it a lot easier to execute it and deliver it and make sure you're meeting all the goals the patient has in mind. So now I know Ralph is probably getting a little nervous when I'm talking about 2D because we are moving into a world where everything is becoming 3D. But I still go back a little old school here. I like to start off with a 2D design a lot of times. And Smilefy has a very easy and great AI-driven 2D design where I can quickly, sometimes at the same appointment, I'll tell my assistant to snap a full face picture, throw it into Smilefy, and start to give some patient some feedback right away. And of course, we all know any kind of visual feedback is really worth more than words, as they say. So I know the outline forms, this is kind of old school, and maybe this isn't that accurate, but it helps me to visualize like where I'm going with this case. And it also enables me to kind of educate and explain to the patient what's going on. Because it's a very simplified way, of course, but it gives us a head start to visualize what's happening. And of course, you can do kind of a mock-up, a virtual mock-up from a 2D. Maybe not so accurate, but it can kind of give the patient a motivational impetus to have the treatment done. They can kind of see what they might look like with your design in place. Now, to get all this going, you need all these records, but probably the most important thing is getting good images. So we need that full smile. This full smile, I'm going to be able to get a sense of the patient's overall look, maybe check out where the incisal edge position would ideally be, how I might want to start making that smile line work with her smile in her mouth and just make it very harmonious with her face. The rested view, I'm looking at the lips, maybe the corners of the mouth, the angular area where I can see if she's overclosed, maybe she's lost some vertical, maybe we need to restore that back, maybe we don't. For the retracted full face, I want to basically make sure is the patient uh, symmetric? Is the midline in the right spot? I also want to make sure, is there any cants that I might have to deal with? Um, the resting profile, once again, I'm looking at the lips, seeing how much support the teeth give us. For the profile and the smile, another visual criteria or visual metric is where that central is in the horizontal world. And this gives me a little head start. This is another photo that kind of gives me some horizontal positioning guides. If those teeth are short of the wet dry line, I know I maybe have some room to work with because obviously phonetically, we can only make the teeth so long and it has to work with speech. But maybe if the teeth are already over the wet dry line, maybe I can add more length to the teeth. Maybe I have to think about bringing them in horizontally or vertically. And we have to follow all the anatomical structures. In the resting lip position, think about this. This is kind of what the patient looks like while they're having a conversation. And no one wants to look older than they do. And if you're talking and you show no upper teeth, it makes you look older. So this kind of gives us a clue. We also know that, hey, we want ideally a few millimeters in this resting lip position. That will look better. That'll have more tooth reveal on smile and talking. For the high smile, sometimes these patients are very conscientious about their smile, and it's hard to get them to smile. You have to kind of joke around with them, see if I can get them to laugh, tell them to show me their gums, whatever it takes. So even in this picture, I've seen her like really smile and laugh, and then she shows more gum than this. But even in this picture, you can start to see, she's got some gum issues. Then, of course, we have our close-ups. We're really diving deep and seeing what's going on. How's the enamel look? How's the perio? What does the tissue look like? Contacts and everything else. We're starting to get an idea about the occlusion in these pictures. Are we going to have some occlusal issues? Do we need to do ortho? Do we need to do surgical intervention of some type? Of course, we have the scans, and sometimes it's easier to look at occlusal views with the scans, but I still like to look at the natural teeth. Here I can see very clearly that the posterior teeth have no wear at all, right? We can see some wear or erosion in the anterior, but nothing in the posterior. That's another clue as to what's going on here for our diagnosis. If we turn the STL into like a stone model, look, we can kind of see wear facets. We can see, how this patient might be functioning, where they're functioning. How are we going to deal with that? Now, before I used Smilefy, and now Smilefy has some ortho visual predictions. They're developing that. I would put it in my old ortho programs and kind of look at occlusion in this view, and maybe some static views or some predictions as to where the teeth might move with ortho, or where can I move them to. Now, so for this patient, once again, we have to break it down. We need that diagnosis. We need to tie that into what are the goals of the treatment, and then what is going to be our treatment plan ultimately. So the diagnosis here, she has some erosion and wear. Now, the erosion can be from internal or extrinsic factors. At this point, it's not that critical in our treatment plan, but it's basically causing her to have super eruption. And now this might be also due to beside the erosion, she has what appears to be a pattern that is, consistent with a restricted envelope or a constricted chewing pattern. It's just her anterior teeth, and it's predominantly the lingual of her anterior teeth. That points us to this diagnosis. And then, of course, she's got some partial edentalism that maybe has contributed to her bite collapsing, but not really. Most of her posterior teeth that are in inclusion seem to be fine. So what are our goals? We want to increase tooth length. We want to lessen the gummy smile. That's one of the patient's complaints. We need to restore and give her back all the lost tooth structure. And she ultimately wants nice symmetry, shape, and she talked about having a whiter shade of teeth. So now our treatment plan, we got to figure out, how are we adding length to the teeth? Are we going up towards the gums, or are we going down towards the incisal? Whitening, is that going to be maybe pre-treatment, or is that going to be built into our restorative materials, or combination? Do we have restorative space for whatever our treatment is going to be? Right now, it doesn't look like there's any restorative space. And then we have to look at, what is our ultimate smile design that's going to satisfy this patient? So when we get into design, let's not lose track that the patient walked into our office with some very specific complaints. And I know oftentimes, and I have multiple practices, and I mentor a lot of young dentists, they lose track and forget about the patient's desire. And then they lose the patient because the patient came in for white teeth and maybe longer teeth, and all of a sudden they're talking about so much other stuff, the patient gets discouraged. So I'm not telling you to avoid or not do proper dental work. You have to include all those things, but make sure you're always reassuring the patient that you understand what their desire is and you are going to deliver that. But you also have to take care of other things. You have to look at the whole aesthetic picture, and the aesthetics for me will drive the case. I know there's other things now, there's occlusion, there's airway, there's other things that people tend to maybe put on the front of the line here. But for me, it's still aesthetics, because after all, aesthetics with health and function, really, aesthetics is just an expression of the health and function. When you see a beautiful or attractive person with a beautiful smile, they have coral pink tissue. They don't have bleeding gums. They have white enamel. Their teeth are aligned. When they smile, they show a lot of teeth. They're healthy. They're fit. They can chew. They can smile. The function and the health really, if you dial that down and get that going, you're probably by default, you're going to have a more aesthetic smile. So, but we tie this all together. And then at the very end, we have to make sure our design, what we're going to do, the treatment is going to be something that's going to be long lasting for the patient. Um, there's nothing more demoralizing for a dentist, especially a cosmetic dentist, and especially someone who's trying to make their name in whatever field they're going to have failure and to have patients starting to not trust you because things are breaking. And also, I mean, you're going to lose money. I mean, if you do veneers for a patient and they walk in the door 3 months down the road and some of those veneers are chipping, well, you're replacing them for free. So you can't sustain a business that way. And just from a personal mental standpoint, you don't want to be looking at the schedule every day and hoping that you don't see one of your patients who comes in every month because something you did isn't working. So having predictable ways to have low risk outcomes is just great for your soul. It'll make you happy and it'll make you have a prosperous and um, really enjoyable practice. So anyway, we have our diagnosis, we have our goals, we have our treatment plan. Now we have to start thinking about how are we going to deliver this treatment plan. So how are we going to get restorative space? And this is really about spatial positioning of teeth. This is less about I want a canine to be pointy or a central incisor to be 76% height width to height rate. This is about where do these teeth belong in some sort of spatial arrangement. So if we look at our virtual models or STL files, we can kind of see these lower teeth are almost inside the structure of the upper teeth. So how are we going to make this work? But we can also see the molars look pretty good, and the occlusal plane and the balance and the occlusion in the posterior is fine. And look, the length of those posterior teeth look pretty good. So it's really just an anterior problem. So for these types of cases, you typically have these 6 options to create more restorative space. And you can procline the uppers, you can intrude the uppers, you can intrude the lowers, and traditionally you could retract the lower teeth. If you procline the uppers, you gain some more overjet for restorative space. If you intrude upper and lowers, you gain more vertical space for restorative. And in the past, we would consider retracting lower teeth to also maybe gain some overjet. But with airway and other considerations, I've kind of shied away from doing this unless it's an extreme case. So we have 3 things in our wheelhouse that all can be done with limited ortho. Now you can also do orthognathic surgery. It's a much more comprehensive approach to reposition and get better spatial positioning. And of course, you can open the vertical. And for restorative dentists, this is a lot of times their go-to because they're not orthodontists and they don't want to send the patient out. So they maybe open the vertical. For our patient here, if we open the vertical, once again, we're not addressing the the um, the gummy smile. We're probably restoring all her back teeth, even if we do it conservative with onlays or tabletop crowns. She's still getting a lot more restorative than she needs. And then we're going to have to still do some crown lengthening. It's not the right treatment. So really for her, proclining the uppers, and intruding the lowers is the way we're going to solve the spatial problem and gain more space for our restorative dentistry. Now, for those of you who maybe don't have as much experience in ortho, proclining the uppers, when teeth erupt, they don't just come straight down. They kind of follow an eruption arc, and that results in very retroclined teeth. So not only are they short and worn, but now they're not in the right inclination. So pushing them back up to where they belong will solve multiple problems. So that's why we want to do proclination and intrusion, get them back to where they belong. So now this is the case. I did this ortho myself. Now notice there's no brackets on the posterior on the molars. I do a lot of premolar to premolar ortho, and I can get a lot of the results and the movement that I need just from that. Because she's got a pretty stable occlusion. She just doesn't have a good pathway. So now I need to shallow her guidance. I need to make the teeth fit properly, allow her to have movement while she's chewing so she doesn't destroy my restorations. So I'm doing ortho, I'm getting the teeth into position, and I won't go through every ortho photo. I'm trying to bring out the inclination so her facial profile is more balanced, lining up the teeth exactly where I want them to be to position them for minimally invasive dentistry. And I'm almost there. And now, once I'm done with the ortho, now we're going into the post-ortho 3D design. So now here's where Smilefy can really save us some time, give us a lot of predictability, and help us execute this case. So we have a video here going through a couple of the still shots, but I'll stop talking for a few seconds and you can kind of see how we go through this. And some of you who are familiar with the software already know this. So we're kind of going through this fast. We have to make sure we get the calibration correct. That's really important. And then we're going to do a mock-up because we want to kind of see how these teeth could look and should look, and then base our treatment plan off of this design. And then we hand it over to the restorative dentist, who is us. So now we're getting into like more of the smile design elements, making sure the teeth are where we want them to be in our mock-up. We can reposition teeth, we can change, we can rotate, we can change angulations, we can change inclinations. It gives us all the tools we have. Now, I fixed most of those problems already with the ortho. So now it's just a matter of a little bit of fine tuning so we have a mock-up that we can work with. And I didn't pick out this music, Carmina did, but it's very good. So now we're getting it down. We can still use this. Maybe if the patient is still not sure about where we're going, we can even show them a simulation. Now, by doing this ourselves, it's almost like a trial run as how you're going to prepare the teeth, what you may need to do in the preparation stage. So I do enjoy doing some of this myself because now I'm looking at it in a whole different way. When I send this out to a lab and they just give me back a model, I kind of don't know like all the ins and outs of what they did, and doing it myself better prepares me for the day when I have to actually break out the drill and start preparing. So there we go. We're almost done. We got our mesh editor out. We fixed everything. And now we've pretty much delivered our design. And now we can use that design in the delivery stage, how we're going to do this. So if you have a printer, that's great. If not, make friends with somebody who has a printer, because the really big advantage of having this software in-house is now you can go straight to your printer or your mill or whatever you're using. In the past, I would have to have someone do this for me. I would have to have them print it. And basically, that would take time, that would take money. Now I can do it all in-house. So I got my printed digital design. From here, I can use it to do an intraoral mock-up. If the patient still wants to kind of maybe test drive it or see it or whatever in their mouth, I can do that. I can create preparation guides. I'll show you those in a moment. I can do provisional prototypes. So I can make a putty matrix and make beautiful temporaries that emulate my final design. And I don't call them temporaries, I call them prototypes because, first of all, I can charge for that. Second of all, it sounds fancy. Third of all, it is actually true. I'm going to use that to help the patient and me decide what we're going to keep and what we're going to change. It's a prototype. I can easily change things as we go along. Now, I won't show you this whole thing, but in my office, I get my model and I start making my matrices. And some people send out and have the lab do this, but if you train your assistant and she probably watched the YouTube video. I showed her how to do it, but she then learned how to do it and got it even better than I can do it. So we get some putty. So this model I can use for so many things. And once I can start making matrices or suck downs on it, it saves me a lot of time. So she's trimming it up here. She's going to get it ready so that when I try it in the mouth, it fits the patient really comfortably. And then she's going to go and do some little notches to make it easier for me to see that it's fully seated, and it makes it easier for the cleanup. And I'll let this play out. I'm afraid if I stop it, it'll freeze my computer, but it's only got another 10 seconds or so. And there we go. She's got a nice finish, beautiful, made it in-house. And then from there, I can make variations on that. So these are all prep guides. So I like to do an initial Luxitemp overlay with my design. So then I can do depth cuts, making sure that I don't take more tooth away than I need to, and really kind of see where my design is towards the gingiva. You can even use it as a crown lengthening guide. I also like to make cuts through my matrix and then lay them on the teeth, and I can really see clearly if I've taken enough tooth away, or in certain areas maybe I need to do more. I can put it and do one for the gingival area to see if I have enough clearance there, and the same with the incisal. And then, I mean, I'm jumping to the final product here, but we would have to do a workshop or something to really go through the whole process. But for the most part, I think most people know at that point how to deliver and make a beautiful veneer. But this case looks beautiful because it was designed well. And then we had preparation and we executed it. And, then patient's very excited, and it kind of resembles what she thought she was going to get when we did the mock-up, when we did the motivational mock-up. We're able to deliver it similar. It's not like we're telling her we can do something and then delivering something not at all what she had planned. Now, we're just about done here. And what I'll do is just preview. Hopefully we can do I do a lot of composites, and I'm going to show you real quickly, and I'll skip over the video, but I like to take broken teeth, maybe at the initial visit, do a very quick mock-up, but take a scan, take some photographs, and then again, use our Smilefy software. And this one, I won't go through the whole thing, but we can use this software to clone the natural tooth, and I'll skip ahead here. So we've got a shortcut, especially when a tooth has some funky kind of anatomy, a lot of mamelons. And so here we're taking the clone tool and we're designing the tooth. And then from there, since we're almost out of time, we can make a matrix. You can make a lingual matrix and do a conventional layered composite. You can do a injection mold matrix. And now, Ralph is developing all sorts and has developed layered matrices for injection molding. So we can get these beautiful results that we all want to deliver for our patients. And I want to just thank you. This is the end of the presentation. And please feel free to contact me on Instagram. I'm usually on there, and I will, respond to any kind of inquiries that you have. And I would love to share my knowledge more with this group. So thank you.
Thank you very, very much for the case and for the presentation. So we have around 300 registered dentists for this webinar. I know not everyone can be live with us, but we send the recording. So as soon as we stop the webinar, we send them an email with the recording. And one of the next interesting cases that we are going to start is just today, just right now, half an hour ago, I released the newest version of Smilefy with the automatic cutbacks. So if you see here, we can now just design. We do have the roots, we have the axial angulations, we have the smile analysis, so we can go through all these important details in the face and harmony to design properly, and the cutbacks are generated automatically. So you just focus on the design, and then you get the cutbacks automatically done. For example, we do have the cutbacks with only the cutbacks. Then we have the incisal support cutbacks. And then you can generate the thimble, you can generate the biometric shrinkage. So everything is done automatically. You just focus on the design, and it's going to be also a very, very interesting way to plan, to try out the smile in the mouth of the patient, but then to have all the files that you need. If you click now on advanced and CAD features and export or composite veneers, you are going to get now 4 automatic generated models. 2 with the cutbacks, 1 full model, 1 with the gap, so that you can prep through the cutback mock-up, and then you get the full design. So you prep through the cutback, you make space for the material, then you have the cutback that you can use, for example, with 1 composite material, and then you can bring the full design to create the translucency and all the high quality restorations. And it's a very, very interesting and exciting new workflow. Yeah, we are super excited to do some cases and then and see the patients then.
I can't wait to try that out. That's like, we've been waiting for that for a long time, and you finally come through. So that's, we really applaud you for that.
And the key is really to have everything automated. Otherwise, we spend so much time to try to adjust the cutbacks exactly the same like the design, and that's very time. Plus, we do have, for example, we can have the cross section, and in the cross section analysis, then we know exactly what is the thickness of the
layer
near and the layer, and just yeah. Now here we have the option to display in our cross section. You see all the layers that we have, the segments, with the root and everything, and so we have a lot of we have the gingiva, we have the gingival margins, we have the axial angulation. So we have a lot of details so that we can plan very, very precisely, and then use the cutbacks. Good. That's from me. Thank you so much for the presentation and everything. If you have questions, you can ask the questions in the chat. Otherwise, we will send you the recording, and our team can help you with all the information if you want to get started or you do have cases. And so our team is going to help you answering the questions and getting started with smile designs, and very important, smile and facial analysis, because that's the key, as in the presentation very, very clearly defined, right? We start with the face, we start with the analysis, and then from there we go and we find the best solution for the patient. So I learned a lot. I will integrate some technical terms, with the facial thirds, and then when you do the analysis in the app, you will automatically get the result of the diagnosis, what is exactly the lower third of the face and all this stuff with the angulations and all this. So I learned a lot. We're gonna integrate more smile analysis in the app so that we make everything even easier. So
that's fantastic, and I look forward to all these these new innovations. Thank you for inviting me to speak.
Thank you. Thank you. So I wish you a great evening. And if you, all the participants in the chat, they know our support email, and Samia just send a WhatsApp email. So if you have questions, please don't hesitate to send us everything what you need, and we will do the best to help you. Thank you very much and have a good night. Thanks. Bye.